Hi everyone, if you are new to this channel, I am Dr. Himadri. Let's talk about ricket. So what is ricket? Ricket is a metabolic disease which is characterized by deficient mineralization of growing bone. Deficient or reduced mineralization of growing bone. That means ricket occurs in children only, because in children you have growing bone. Okay, so what is the adult counterpart of it? This is called as osteomalacia, where there is reduced mineralization of bone in adults. Okay, so another thing, what is osteoporosis? Osteoporosis means the organic matter of the bone is reduced as well as the mineralization part is reduced. Okay, so what is the pathophysiology of ricket? You have metaphysis of the bone, you have epiphysis. In between the metaphysis and epiphysis, you have the cartilaginous growth plate. In the cartilaginous growth plate, we have multiple layers of cells. Initially the cells are resting, then they appears to be growing, then there is hypertrophy. In the calcification zone, the cell usually undergoes apoptosis or cell death, and this is triggered by sufficient amount of phosphate. If there is reduced amount of phosphate, then what will happen? The cell will not undergo apoptosis, therefore the chondrocytes will keep on proliferating. As well as another thing you must remember, that vitamin D is like a supervisor for calcium and phosphate deposition or calcium phosphate mineralization in the bone. If there is reduced amount of vitamin D, there will be reduced calcium and reduced phosphate mineralization in the growth plate. So this is the actual pathogenesis of rickets, and this is where the story actually begins, that is reduced phosphate. And in India and other countries, the resource restricted countries, we have reduced amount of vitamin D, usually nutritional. So we must know the causes for rickets. One thing is calcipenic rickets, and another form is phosphopenic rickets, where there is calcium, there is reduced amount of calcium as well. So what is the most common cause? Most common cause is vitamin D deficiency, usually nutritional deficiency. Suppose if a child is taking only breast milk less than 1 liter per day, then there will be this deficiency, because in breast milk there is reduced amount of vitamin D, as well as due to malabsorption, reduced vitamin D absorption, or maybe due to chronic liver disease. Chronic liver disease is an important cause as well. And we have few drugs as well that will lead to vitamin D deficiency, like anti-epileptic drugs like phenytoin, or ATD, anti-tubercular drugs like isoniazid and rifampicin. Okay, and apart from this vitamin D deficiency, we can have reduced amount of calcium. This calcium deficiency may be due to prematurity, but remember, the most common cause is nutritional deficiency of vitamin D. So in this classification of calcipenic rickets, we have few other causes apart from this nutritional cause, like VDDR, that is vitamin D dependent ricket type 1, type 2, CKD, as well as RTA type 1 or distal RTA. And we have phosphopenic rickets. What are phosphopenic rickets? If there is reduced amount of phosphate, let's say a baby is premature. Due to prematurity, the phosphate reserve may be low, as well as suppose a patient is taking antacids. So these antacids basically leads to reduced absorption of phosphate. So these are two important causes for nutritional phosphate deficiency. We have non-nutritional phosphate deficiency associated rickets as well. These are due to FGF23, that is fibroblast growth factor 23 dependent renal wasting, or maybe FGF23 independent renal wasting. So what are the causes under FGF23 dependent renal wasting? We have familial hypophosphatemic ricket. So this could be due to autosomal dominant cause, or autosomal recessive, or X-linked recessive condition. Okay, and we have tumor induced osteomalacia, or we could be or we may be having McCune-Albright syndrome. Okay, so another category is FGF23 independent renal wasting. The cause could be hereditary hypophosphatemia with hypercalciuria, or we could be having RTA, that is renal tubular acidosis, usually type 2, that is proximal RTA. What are the clinical features of rickets? Patient could be having craniotabes, that is ping pong skull. There is reduced mineralization, that is why this is happening. And also there could be wide opening of anterior frontally, and there could be frontal bossing, These things is actually happens when the disease becomes chronic. Okay, and also there could be dental that is a delayed dentition, or could be enamel hypoplasia. Okay, and you can have rachitic rosary. What is rachitic rosary? These are usually round. Okay, in scurvy, what you can see, that are sharp as well as painful, but in rickets no pain. As well as there could be wrist deformity, wrist widening, and also you can see in this photo what is happening. There is bilateral genu varum deformity. Bilateral genu varum deformity means we call it bow leg. Okay, the legs are turned inward or medially, and from the knee joint the leg could be turned outward as well, that is laterally. We call this knock knee or genu valgum. Or there could be wind swept deformity, that is one leg valgum, another leg verum. What are the investigations that you would like to give to this patient? It could be ALP. The most important is the ALP. ALP is raised in all causes of rickets, and also serum calcium, serum phosphate, serum creatinine, and albumin. These 4 investigations you must keep as a first tier investigation in ricket. The ALP is increased in all cases because there is deficient mineralization, and also the phosphate is reduced in the blood. Only one condition, only one exception, that is CKD, where phosphate is increased. Okay, so another thing, another optional investigation is 25 hydroxy vitamin D. It is usually deficient because the most common cause is vitamin D deficiency. Remember, less than 12 nanogram per ml. Okay, and the second investigation is your X-ray, bilateral wrist and knee joint X-ray you must order. And the changes that happens are, that is the irregularity at the end of the long bone, which is called as fraying. And also due to weight bearing, what happens, the end of the long bone becomes curved inward, this is called as cupping. And also the lateral part of the bones goes outward, this is called as your splaying. So 3 things happens in chronological order, that is fraying, cupping, and splaying. Here you can see in the bone we have fraying, and also you can see the cupping, and now you can see there is splaying. Okay, so once again there is fraying, cupping, and splaying. What is the treatment for ricket? Remember, as the vitamin D deficiency is the most common cause of ricket in resource restricted settings, we have the treatment is vitamin D. Earlier we were giving STOS therapy, that is 60 that is 6 lakh international unit. Now we are not giving like this. We have now the regimen like less than 1 year of it, 2000 international unit per day, more than 1 year of age, 3000 international unit per day. It should be given for 3 months along with calcium supplementation at 30 to 75 mg per kg per day for 2 months. So vitamin D for 3 months, calcium for 2 months, and after that 1 year you must give vitamin D, and that should be given 400 to 600 international unit. Okay, thank you.